Welcome to this podcast from the Medical Journal of Australia. My name is Sam Hunt, the MJA's News and Online Editor. Today we are discussing the supplement in the Medical Journal of Australia from the Office of the National Rural Health Commissioner on the theme, Building a Rural and Remote Health Workforce with Place-Based Education. My special guests today are National Rural Health Commissioner Adjunct Professor Ruth Stewart, who has more than 30 years' experience as a rural generalist obstetrician, and Professor Richard Murray, who is the Dean of Medicine and Dentistry at James Cook University and the immediate past president of Medical Deans Australia and New Zealand. Adjunct Professor Ruth Stewart and Professor Richard Murray, thank you so much for joining me today.
Thank you very much, Sam. It's great to be here. We're looking forward to having a chat.
A pleasure, yeah, delighted. Thanks.
Ruth, I'll start with you. As the National Rural Health Commissioner, can you please take me through what is the role of the National Rural Health Commissioner?
The National Rural Health Commissioner is an independent statutory officer. So statutory means that it's established by legislation. And I'm independent of the Department of Health and the Minister, but obviously I need to work closely with both of those to consult with key stakeholders in rural and remote health to develop advice for the Minister for Regional Health to improve the health of rural and remote people in Australia.
And Ruth, let's turn to the supplement in the MJA on building a rural and remote health workforce with place-based education. What are the most pressing rural health challenges that face regional areas?
Well, rural and remote people die earlier, carry a heavier burden of disease than their metropolitan counterparts, but have much poorer access to healthcare. And a lot of that poorer access to healthcare relates to lesser workforce in rural and remote Australia in health. So that's our biggest challenge, to increase and improve the health workforce in rural and remote Australia.
And Ruth, you have written in your editorial that the affiliation of medical schools with large teaching hospitals has not resulted in evidence-based care. Can you take me through what you mean by this?
Okay, so our medical schools are now affiliated with what we call tertiary teaching hospitals, and that followed on from a very influential American report into medical education, the Flexner report, where and the result of that report was great efforts to increase the scientific teaching in medical training. And the thought was that if there were strong affiliations between universities and large hospitals, that we would improve the scientific basis of the medical education and the medical practice. If you've ever looked at any of the publications from the Dartmouth Atlas and indeed our own Australian Atlas of Health, you'll see that there is actually a huge variation in healthcare across Australia and within the United States that does not seem to be driven by the health needs of a community or by what is available. It seems to be driven much more by what particularly doctors want to do. So we're not serving our populace well. And I consider that fact and think about what we know about rural health education. And we know that where there's a strong base in the health needs of a community and learners, students are based in community and connected to community, there's a much stronger understanding of what services are needed and how you can train for those to provide those services. So I think that reflecting on the unwarranted variation in healthcare and what we now know from 25 years of rural health multidisciplinary training program in Australia, that we could get ourselves much closer to providing the healthcare that rural communities and other parts of Australia need by integrating our learning our learning events with community.
And I'll turn now to Professor Richard Murray. Richard, can you talk me through the challenges of developing a pipeline of doctors who want to practice regionally?
We know a lot, Sam, about what we need to do to produce out of medical schools graduates who willingly pursue careers in rural, remote and regional areas. We've got a lot of evidence from Australia and from overseas, really over 20 plus years. And the trouble is that a lot of what works is not the legacy history, as Ruth has outlined, of how medical education has been arranged. So I think we do a really good job of graduating high-quality doctors in Australia. The trouble is that if you have a system where most of those who go into medical degrees are from major metropolitan areas and often from fairly affluent professional backgrounds, private schools and so on, the usual sort of concentration of those who get into medical school. And then the training and experience is predominantly in large tertiary metropolitan hospitals. Again, important settings for training, but the dominant experience. And indeed then the training that goes on beyond medical school through the phases, early graduate and then on through training into a specialty, general practice, including rural generalism or one of the other 80-odd specialty areas. Most of that, again, is arranged in major capitals. And so why would we be surprised, in a sense, that this doesn't tend to produce the doctors in the right places with the right skills and the right qualifications? And so that's the history. I think it's really important to look at this, Sam, as what has been achieved as well that we can build upon. And I think Australia's actually done, as Ruth has outlined, a lot over the past 25 odd years to try and turn that around. And I think we're progressively moving in the direction of trying to locate more of the education and training in community and primary care settings, as well as in regional, rural and remote locations. There are a few big challenges, and could outline some of them, but probably the largest of which is that we just have the settings of a legacy system of training, where an acute public hospital is the predominant location where training occurs, and that the experiences and the peers and the identity formation and the stories and the inspiration that might come from community, indeed from aged care, from disability, from mental health care in the community, whatever it might be, do not feature and are not part sufficiently of the training system as we know it at present.
And Ruth, as the National Rural Health Commissioner, where are you focusing your energies as Commissioner in terms of boosting regional workforce initiatives?
I would say that where I'm focusing is on the pipeline. Now, Richard Murray, in his leadership at James Cook Uni, has demonstrated that if you connect all the pieces of the training pathway, you can very ably deliver doctors to rural and remote communities across this. Richard's doing it for far north. North Queensland and also influencing in the Northern Territory and Northern WA. So if you select students of a rural or remote background, if you bring them into a course that has explicit curriculum on rural and remote medicine, if they have early and repeated and well-supported clinical attachments in rural and remote health, if they're taught by practitioners who have experience and expertise as rural clinicians, if they then can have a clear line of sight to a career in this case, rural health, and if there are jobs that they can go into, then you can make doctors now who will work in rural and remote communities. And James Cook University has been proving that for the last 20 years. So there are other programs around Australia that are now reproducing the excellence of James Cook Uni, doing it in their own way for their own community and region. And one of my roles is to support that, but particularly to look at stopping the holes in that pipeline, making clear the pathway to rural and remote jobs, so that we know that one of the at present neglected but very influential pieces of that pathway to a rural health career is your first job after you graduate, whether you're a doctor, a nurse, or an allied health practitioner. So in medicine, if your internship is in a large tertiary hospital in a metropolitan centre, we can reduce by 75% the number of graduates who'll become rural doctors. But if you give those graduates an experience in rural and remote Australia, you stop the leakage into the city, and you provide more doctors for the bush. So I'm focusing a lot of my energy on encouraging an increase in the number of internships and early career jobs in rural and remote, and encouraging policy that will support that. One of our complications is that job internships are largely controlled by jurisdictions, so that's you can't just talk to one person. But and I work for the federal government, but there are mechanisms within policy that the federal government can execute, such as the National Health Reform Agreement, whereby the money that is passed from the federal government to the jurisdictions for hospital care can come with some strings attached. I'm hoping that there'll be more attention paid to outcomes in rural and remote Australia in the next round of the National Health Reform Agreement, including internships outside of metropolitan services. And I'm also hoping that there'll be more focus on rural maternity, but that's a discussion for another day.
And Professor Murray, Richard, let's talk about the solutions. Let's talk about primary care. What kind of changes are you advocating for to improve primary care in the regions?
Thanks, Sam. It's such an important topic. If we're to have sustain and grow a really world-class healthcare system, we have to have a very strong base of primary care, multidisciplinary, comprehensive, high-quality primary care. That is under threat, I think, and that's not something that many would dispute. And certainly I welcome this government's commitment to strengthening primary care, the strengthening Medicare reforms, for instance, map out some of where we need to go. I think the missing piece is the realisation that you don't get the workforce into general practice or rural generalist medicine. It doesn't just appear. It needs to be recruited, nurtured, grown, inspired, trained, and ideally, as Ruth has explained, in settings and in locations where folk are needed. The from, in, with, and for agenda for priority communities. And so that's the piece that we need to focus on. And look, I mean, for instance, to illustrate this, in the current year, for instance, the federal government via the Hospital Funding Authority, the Independent Hospital Aged Care Pricing Authority, contributes $2.2 billion to the teaching, training, research capacity of our public hospitals, important investments, but really nothing of any substance to the primary care sector, general practice, and other community-controlled health services, aged care and other services, and not featuring in investments for teaching, training infrastructure for the country. There's a grab bag of programs relatively modest compared to that scale. They'll probably sum up to about 5% of $2.2 billion that represent the investment into the teaching capacity of a primary care system. It's a real missing piece. Unless we have a high-quality, inspiring, learning, teaching, and ideally research-intense primary care sector, where GPs who are passionate, with an interest in bringing on the next generation, in following up on ideas and developing new knowledge, to improve the health of Australia's community, at the moment really don't have many avenues to pursue that, unlike in a public hospital system. I think this is a really important issue that's been identified by medical deans as a key missing capability in Australia's healthcare system, and must be addressed if we are hoping to turn around and strengthen the primary care sector, rural as well as in the city.
And how do you make sure that postgraduate training is put in place in regional areas to make sure doctors in training wanting to study and develop in regional areas can do so?
I think we've done quite a bit of reform in the entry qualification to your medical career, which is your medical degree, to try and move a lot more of that into the regional area. So there's a lot of action there. We've not had quite as comprehensive an approach to what goes on in the early years after you graduate, as Ruth has outlined. I do think we do tend to have a system that may knock the rural stuffing out of rurally inclined graduates, because really there's no obvious pathways. There's no support and tracking to pick to get yourself onto a pathway to become a rurally based, regionally based a GP, rural generalist, let alone a rurally based general surgeon or a rurally based physician or paediatrician. There is no obvious pathway for this. And look, we know life happens. Life happens to people, as they're going along the track. And if you spend a significant number of years after you graduate milling around major teaching hospitals, picking up your qualification, where are you likely to meet a life partner, have children, buy a house, join a sporting club, whatever. Life happens. And ideally, you need that life to be happening outside of major cities. Medical Deans is calling for a much more comprehensive, really whole of government, all stakeholder approach to moving as much as possible into regionally based further training as a recent graduate, and then in training to a specialty area, including and particularly actually general practice and rural generalist medicine. And rotating into cities, flipping the model, if you like, rather than the other way around. It's not a new idea, but we do need to combine that. We're talking about regional training collaboratives. At the level where you can know who's who and what the opportunities are and what the community needs are, being able to support all trainees as far as possible locally to pursue high quality training, not alone, not in isolation, but in groups, in cohorts, able to share infrastructure and supports in a much more deliberate way to furnishing the future workforce that will willingly pursue careers because they're excited about it. There's a lot to be excited about regional careers, but if you don't see it, you don't know what you're missing out on, and you can end up in yet another consultant in a major city.
And Ruth, I'll go to you. Any final comments?
So I'll pick up on Richard's comment about if you can't see it, you can't bear it. We need to have our students and junior doctors seeing the experienced rural clinicians and being inspired by them. Often when I talk to young doctors who have become rural generalists and rural GPs, there has been a transformative moment or series of moments where they saw someone and thought, I want to be like them. How do I do that? So we need to have a greater presence, both of rural doctors and clinicians in the universities, but also as well as bringing the students out into our rural communities.
National Rural Health Commissioner, Adjunct Professor Ruth Stewart and Professor Richard Murray, thank you so much for joining me today.
Pleasure, Sam.
Our very great pleasure. Thanks, Sam.
My special guests have been National Rural Health Commissioner, Adjunct Professor Ruth Stewart, and Professor Richard Murray, who is the Dean of Medicine and Dentistry at James Cook University, and the immediate past President of Medical Deans Australia and New Zealand. You can read the supplement in the Medical Journal of Australia. You can find more podcasts on our website at mja.com.au or wherever you get your podcasts. Thank you so much for listening.